I'm going to speak on a very, very important topic. I call it a bi-directional talk. One is on a molecule which has been hailed as the molecule of the decade. And second, about a concept which is absolutely fresh from the oven. How can we use the DAPA and DAPA plus M, most important DAPA plus M, as the first line drug? Jayant, I assure you, I will not exceed time. So I'll be a little fast in talking, but I'll touch upon all important points. You know, type 2 diabetes, 15 minutes, yes. Type 2 diabetes from its onset to diagnosis to complications gives many windows of opportunity. And one of the windows of opportunity we have today is to reduce BMI, even in the pre-diabetes stage or diabetic stage, to bring it down to green zone from to red. We have ways and window opportunity to reduce the risk of the microvascular complications in kidneys, nerves, and eyes. And we have many other opportunities, which I'll discuss in a minute. Now, SGLT2, to a very, very brief summary of them, they are insulin independent. They work without insulin. Number two, they do not care for the insulin resistance. They are beyond insulin and beyond IR. Number two, apart from the hyperglycemia, they also work on hypertension, dyslipidemia, and obesity. That's very important. You know, the diabetes and call it as a polypill because it serves at least 4 to 5 purposes, single pill. But the nephro and cardios call it as a magic bullet. I'll show the presentation, or a magic pill. But you know, for the type 2 diabetic patients, it's a polymagic pill. Please remember, for the type 2 diabetes, it's a polymagic pill. I have taken 18 presentations, but only the titles to show that the SGLT2 is the future, it is the star, it is the year or the decade of the SGLT2 inhibitors, and also it's a magic bullet, as nephros and diabetes call it, and the effect is beyond glucose lowering. But most important, today, what is gaining importance is the first line therapy of type 2 diabetes mellitus. Now, there's a very seminal presentation which says that SGLT inhibitors are the first line therapy for the diabetics with severity, no doubt about it. We'll come to it. And also its presence is effective in the HF-ref, HF-PIF, and the pillar of care for the hypertension and the reducing hospitalization, etc., etc. There are also papers, 6 papers are posted here, which shows the importance of DAPA for the CKD. We cannot forget it. The importance of DAPA for CKD is DAPA CKD, and the other trials have shown very clearly how DAPA works as a renal protector, how it works in every severity of CKD, and how we can have a victory over the CKD with this new drug, etc., etc. I will not time on it. But most important issue that as per the ADA 2022 criteria published 1.5 months back, the therapy recommended should include multiple and concurrent evidence-based approach to take care of the not only glycemic management, BP management, lipid management, and cardiovascular and kidney management. And DAPA foots the bill. Dear friend, across the spectrum, whether monotherapy or add-on to metformin, add-on to SU, add-on to DPP4 plus minus metformin, add-on to insulin plus minus OADs, you see the amount of reduction in HbA1c versus the placebo. So it's a very effective anti-glycemic agent. And about the weight, you see the glipizide and metformin, you see the weight gain is 0.136. In same time, here the weight loss is minus 3.7. So DAPA gives a weight benefit of more than 5 kgs. Now it is not just the glycosuria and the weight. We wrote a paper in JAPI, we called it is a vascular euphoric drug. You know, me, Mangesh, we wrote it together. And you know, why it is a vascular euphoric drug? Because it has a lot of vascular benefits. Metformin has a lot of, we call it metformin is a metabolic cum vascular drug. Metabolic cum vascular jada. So similarly, today, the combination of both the dapagliflozin and metformin stands out as a very prominent vascular drug, taking care of the hemodynamics, taking care of the various issues, muscle cells, monocytes, macrophages, endothelium, the PCT, the cardiac fibroblast, adipocytes, cardiomyocytes, and having a very, very beneficial effect on the blood pressure, arterial stiffness, atherosclerosis, endothelial function. So this is a pleiotropic effect on the cardio and vascular system. Dear friends, today DAPA is hailed as a game changer. I'll tell you that DAPA HF is approved by FDA for the HF-ref, And in the updation of guideline of 2021 in 2022, of course, in ACE and the NICE, the Dapagliflozin has been approved even for the CKD in diabetics, and of course, for the cardiac and diabetes and the kidney, both diabetics and non-diabetics. But most important, 2019, the European Society of Cardiology gave a clarion call that this should be the first-line therapy. And the generic dapagliflozin, once it came and became very affordable, the guidelines have included, including RSDA guideline, that dapagliflozin as a first-line of drug for the type 2 diabetic patients who have, I'm qualifying it, who have atherosclerotic cardiovascular disease or a spectrum of cardiac risk factors. So today, the only affordable SGLT2I for glycemic control, HFrEF, and kidney disease has been DAPA. Dear friends, you see here, in the pre-DAPA generic era, October 22, the DAPA was number 18 drug. Today it has come to 18 drug. Lo and behold, it has been estimated that within 6 months, it will reach top 3 drugs. What does early addiction of DAPA do? Dear friends, I have got 6 slides to show the benefit of the early DAPA. Number 2, we have to bring our clinical inertia in managing the cardiorenal risk. As Jyoti said, if you do not adopt technology eat us up. If you do not tackle cardiorenal risk, this CRM risk will take over us. Now, why we should start? We have got about 5 inertia. We say we don't have personal experience of prescribing this drug alone or with metformin. You start early. Skill comes through practice. Prescribe, practice, skill come to you. Competing priorities like obesities, but you have to address the comorbidities. Therefore, you have to give a drug which takes care of both. You say you have a limited knowledge about this drug, but there's a strong cardiorenal metabolic benefit and evidences which nobody can close eyes to. Lack of interdisciplinary, how can I prescribe a cardiac drug, a renal drug? But dear friends, we have to develop communication with the patient and also with these specialties which take care of it. Treatment re-evaluation, we must evaluate, monitor these parameters to show the benefit and feel ourselves. Now, if you add DAPA metformin or DAPA and DAPA plus M early, you see early versus later use of dapagliflozin was associated with a greater likelihood of adjusted H1C reduction of more than 1% than adding it late. So early addition of dapagliflozin, DAPA plus M is very beneficial, not only for the blood sugar correction. You see, even if you initiate the drug as a second-line drug, if the patient does not have the cardiac factors, do not have the ASCVD, metformin number 1, then you add the second-line drug as dapagliflozin. You see, among all second-line therapy, take all the drugs in second-line therapy from metformin to SGLT to all other drugs, DPP4 issue, you find that this lowest treatment change or lowest discontinuation, meaning thereby patient accept this therapy very much. If you give early initiate dapagliflozin, there is benefit of lowering of the MACE in patients who have ASCVD and severe risk factors, and impact is more marked in the patients who have more number of severe risk factors. So MACE and severe risk factors are less. Here are 5 benefits of early addition of dapagliflozin. Number 2, early intervention, achievement of glycemic control, reducing the long-term risk of micro and macrovascular complications. Number 2, this has been found in patients with or without diabetes. Early use of DAPA in newly diagnosed type 2 diabetes mellitus reduces the progression of atherosclerosis, improves glycemic control compared to other therapies. It shows benefit of delaying, at least postponing, onset and worsening of renal complications. It by lowering serum creatinine, reducing albuminuria, and decreasing mortality associated with renal kidney disease. This is all over the place in the literature. DAPA is also under evaluation today for the treatment of NAFLD, the non-alcoholic steatohepatitis of the liver. Not final word is not available for the obesity, but we know absolutely clearly minus 3.5 to 5 kg weight loss can be there. It's being evaluated for type 1 diabetes, acute MI, dyslipidemia, and insulin resistance. Though dapagliflozin as an early addition makes a suitable first-line drug. What does guidelines say? Very important. You see, ADA 2021 said indicators of if the patient has indicates high risk established ASCVD, CKD, or heart failure, one can consider adding the drug which is meant for them, that dapagliflozin. And if you see ADA 2022, again it has said they recommended independently of baseline blood sugar. If the patient has ASCVD, heart failure, has got CKD, this becomes the first line drug. Otherwise, metformin plus the metformin plus this drug. Now, these are the few recommendations of NDA 2022. First line therapy depends on the comorbidities, patient-centered treatment factors, and management needs, and generally includes metformin and comprehensive lifestyle modification. Other medications, the point focus here, SGLT2I, mostly the DAPA, the generic one, with or without metformin based on glycemic needs, are appropriate initial therapy for individuals with type 2 diabetes at high risk of atherosclerosis, cardiovascular disease, heart failure, or CKD. Early combination therapy extends the time to treatment failure. If you start it early, the treatment failure time is extended. Number two, patient-centered choice is the most important thing now. The 2019 European Cardiology Guideline, which says that even the patient on metformin or drug-naive patients, if there is ASCVD, CVD, they said they even did not go to say ASCVD. They are the cardiology guideline. They said ASCVD, CV risk, organ damage, multiple risk factors, start SGLT2 first, then add metformin, or if there's a metformin already there, add this dapagliflozin and continue it. Now, what are the proven cardiovascular benefits of dapagliflozin? Dear friends, I have no time. The declared TIMI is the trial for prevention of the cardiac onslaught. The CANVAS program, the DAPA CKD program, and DAPA HF program all have showed there's a great benefit on the atherosclerosis, for the myocardial infarction, on the diabetic cardiomyopathy, heart failure, and cardiovascular death. So much so that the heart failure benefit 1 in 21, the mortality benefit 1 in 46, and 1 in 19 the benefits, overall cardiovascular benefits. Now, I'll not go to the patient because of lack of time, but there's a patient who had STEMI, also had a percutaneous implantation. He had referred 3 weeks later for a follow-up examination, history of diabetes 6 years, dyslipidemia 4 years, the blood sugar in hospital 160 to 180, along with other OADs. He's on cardiac medication. He's obese, BMI is 26.8, and the fasting glucose 121 and 160. Now, if you see any patient, we see every day in our clinic who have got type 2 diabetes mellitus with heart disease, because heart disease is very closely related to diabetes. Diabetes itself is, in 2004, they declared diabetes as heart disease. So it's very closely related. So if a patient has type 2 diabetes, high risk of MACE or CV death or heart failure, the drug of choice is definitely dapagliflozin. The SGLT2 inhibitors, and we are talking here the most affordable one. And here is shown the effect of dapagliflozin for 10 milligram versus placebo. You see the effect on the MACE, CVD, heart failure, and the renal benefits. So therefore, the risk factors without established CVD, if the risk factors are more, it has been also said that DAPA is the drug of choice. In declared TIMI, patients with prior MI experienced a significant 16% RRR, relative risk reduction in MACE, and absolute risk reduction in 2.6 to 3% cases. Now, only concentrated on this dapagliflozin reducing the risk of HHF, hospitalization because of heart failure, and adverse renal outcome is independent whether patient is old or young, male or female, obese or non-obese, early diabetes or duration of diabetes longer. But if you give towards the late, the benefits are less and you are losing the window of opportunity, irrespective of HbA1c, irrespective of eGFR, irrespective of the previous history of heart failure and number of risk factors. So dear friends, the dapagliflozin has been used as a primary preventing drug in the primary cardiovascular prevention cohort in declared TIMI 58 trial, only one trial of its kind across the board to reduce to produce primary prevention of the heart disease and diabetes mellitus. Now, in DAPA HF to preventing heart failure, I've just shown one slide, not beyond this. You will find that the 26% relative risk reduction of the heart failure and number needed to treat is 21. See the immense benefit of this. Next, we'll pass on to the mechanism. The mechanisms are not clear. We do not know whether it is because of the augmentin diuresis, because of the excitation contraction coupling, whether it is because of the keto pathway of the metabolism, nephroprotection, whether it is improving autophagy, decreased inflammation, decreasing fibrosis, whether decreasing epicardial fat. All these are being investigated, and most of them are shown to be true. But there's also mitochondrial aberrations, which are also set right by dapagliflozin. But the truth of the pudding in eating it, we know for certainty, whatever the mechanism, SGLT2 has great benefit on the heart failure and these risk factors. Dear friend, you take any type of diabetic patients, any type of patients having heart failure, whether type 2 diabetes, even non-type 2 diabetes, background heart failure therapy, they're on any therapy or devices or not. Baseline LV ejection fraction, whether it's 35 or 25 or it's only 55. Renal function, eGFR is more than 60 or even less than 60. Diuretic therapy is there or not there. The heart failure etiology, whether ischemic etiology, non-ischemic etiology, systolic blood pressure high or low, whether patient already on nephrolysin like sacubitril and valsartan, whether baseline NT and pro-BNP are high or not so high, across the presence of heart failure, dapagliflozin produces consistent benefit in all varieties of patients. Dear friends, about the kidney, DAPA has cut the incidence of worsening kidney failure by 40% with a number needed to treat of 19. I was referring to this to prevent one primary outcome. Even after a median of 2.4 years, we need 19 patients to produce the benefit, a great benefit. So this graph shows the primary outcome benefit, 39% I told you just now. And also I showed you the various secondary outcome benefit of the kidney failure. In the DECLARE TIMI 58, they also looked after the kidney problem and they found that they had a slower kidney disease progression and reduced the event on the kidney disease. The A1C microalbuminuria came down by 46%, albuminuria by 21%, and albumin category reduction by 27%. Now, amongst all dapagliflozin, generic dapagliflozin is an ideal for the SGLT2 Indian setting. You know, we have a saying in the government of India, Indians are brand conscious, more than brand, they're the price conscious. So therefore, the Indian patients who have higher abdominal adiposity, who have higher waist circumference, low level of adipokine, high plasma leptin, low rate of glucose disposal, impaired insulin secretion, the SGLT2 can reduce body weight, reduce waist circumference, reduce triglycerides and the leptin, and increases the rate of glucose disposal, improves beta cell function, not yet totally proved, and improves insulin resistance. This is a beautiful concept. You know, the least cost effectiveness is in this quadrant. Best cost effectiveness in this quadrant. What is the least cost effectiveness? Is the best cost effectiveness is the Indian generic dapagliflozin, because at a price of 10 rupees average, we can get maximum benefit of all the SGLT2. And no, least assured utility, other events do not produce assured utility in all this renal, stroke, quality of life and life years. And remo also become more costly because of giving drug twice a day. Therefore, dear friends, before I close, I must tell you that for decades, good glycemic outcome control was the only way to reduce CV and renal risk in diabetic patients. DAPA can prevent, the generic DAPA and more so generic DAPA plus metformin can prevent CRM risk, cardiorenal metabolic risk, independent of the H1C travel. And in the beginning, we said it reduces A1C across the board. DAPA and DAPA-HEM have impacted type 2 diabetes treatment, heart failure treatment, and CKD guideline across the globe to define a new standard of care to use it at the first line treatment. The treatment naive patients with type 2 diabetes mellitus, DAPA plus M is well tolerated and effective in reducing H1C, FPG, and weight. And much before this drug, this was become generation came, we had cut down the price by giving combination of DAPA plus metformin, and we have used it plenty and found great benefit. Low cost DAPA and DAPA plus metformin is an effective, safe, and reasonable choice for the treatment of type 2 diabetes patient with multiple risk factors and multiple comorbidities. So therefore, DAPA should be initiated as first-line therapy. Before I close, I'll just tell a story of two American presidents. Now, it is one president died because of tuberculosis, because anti-TB drug was not available. But one other American president, Roosevelt, he died of hypertension. When Pickering and Platt were debating whether hypertension is somebody's personal property, whether hypertension treated or not treated, he died of brain hemorrhage. Dear friends, I personally believe having a generic dapagliflozin, which is affordable, which is appropriate, which is available and easily accessible, AAAA, the generic DAPA, not to use it is no more acceptable. Thank you very much for the time you gave me and also for a very patient hearing. Over to the chairpersons.